Today we'll be talking about the management of asthma in the Pediatric Emergency Department. I'm Iman Lubani, one of the pediatric emergency physicians at London Health Sciences Centre. I'm also the Pediatric Emergency Medicine Undergraduate Medical Education Director and an assistant professor at Western University in London, Ontario, Canada. Our objectives today are to define asthma, to develop an approach to the history and physical exam in a child with an asthma exacerbation, to review the red flags on history and physical exam that might indicate increased severity of the exacerbation or increased risk of that exacerbation, to review the PRAM scoring system in categorizing asthma exacerbations, to develop an approach to the management of the child presenting with asthma exacerbation, and to review the criteria for ED discharge in a child presenting to the ED with an asthma exacerbation. So first we'll start with a case. We have a 12-year-old girl by the name of Aya who's had a 3-day history of cough, a 2-day history of wheeze, and today has had increased work of breathing. Her puffers have been used at home but are not helping. When you examine her, she's alert, but she's got a tracheal tug, intercostal indrawing, and she's not able to speak in full sentences. Her temperature is 37, her heart rate is 130, her respiratory rate is 50, and her oxygen sats are 89% on room air. Respiratory exam shows decreased air entry throughout, with no crackles but occasional wheezing, and cardiovascular and abdominal exams are normal. On past medical history, she does have a diagnosis of asthma and is followed by pediatric respirology. She's had multiple previous ED visits, and she's been hospitalized about once a year since her diagnosis a few years back. She's had 2 previous ICU admits as well, but never been intubated, and she has a history of eczema. Her meds include Ventolin as needed and Flovent regularly every day, and her immunizations are up to date. So how do we define asthma? Asthma is a chronic inflammatory disease of the airways, usually the lower airways, and it has a lifetime prevalence in Canadian children of 11 to 16%, which is quite high. An asthma exacerbation is an acute or subacute deterioration of symptom control in a child with asthma, leading to respiratory distress and the need for medical treatment. Anywhere from 3 to 7% of all pediatric ED visits in Ontario are for asthma, and about 10% of ED visits for asthma result in hospital admission. So these are quite significant numbers. Things to ask about on history in a child presenting with asthma exacerbation. Ask about preceding symptoms, so things like cough, runny nose, fever. Ask about shortness of breath, the duration of symptoms and the duration of the shortness of breath, the severity of symptoms. Ventolin use, how often are they using it since the exacerbation, and how often do they use it at baseline? Inhaled corticosteroid use, is it something that they've been prescribed, and if so, are they actually using it as prescribed? I ask about past episodes, so the frequency of these asthma exacerbations, as well as their underlying symptom control. So looking for things like exercise intolerance or frequent Ventolin use at baseline might show you that they're poorly controlled at baseline. Past ER visits or admissions would also hint at poor control of the asthma. ICU admissions will make you worry about a child who might progress to having more severe symptoms and requiring admission. And systemic steroid use, how often have they required systemic steroids? I also ask about smoke exposure at home, both as a method of counseling parents, because this is something that's quite important. Smoke exposure is known to exacerbate asthma symptoms, and also to get a sense of the severity of this child's asthma. Family history. So a family history of asthma or a family history of eczema, hay fever, any atopy is important because that might point you towards asthma as a diagnosis in a child or severity of asthma. On physical examination, you want to start by looking at the child's airway, breathing, and circulation. So making sure that they're stable overall. Their vitals, their temperature, oxygen saturation, signs of tachypnea, signs of tachycardia, and looking at their blood pressure. And you're also looking for signs of increased work of breathing, such as intercostal indrawing or subcostal retractions or tracheal tug. Hypoxia and cyanosis are very ominous signs in an asthma exacerbation, as well as altered level of consciousness, which often is secondary to hypoxia or secondary to low oxygenation. An inability to speak in full sentences is also an indicator of an increased work of breathing. Decreased or absent air entry, wheezing, harsh breath sounds are all things that we're looking for on physical exam. And then signs of kind of more long-term poor control of asthma, things like barrel chest or clubbing. So the child having kind of a more rounded barrel chest would indicate that this is a child with poorly controlled asthma at baseline. These thankfully are rare findings here in Canada because most kids don't have asthma that's poorly controlled, and we often manage these children's asthma well enough that they don't progress to that point. Some red flags that might indicate the need for ICU admission, things like greater than 2 ER presentations for asthma in the past 12 months, because that will indicate poor underlying control. Increased IgE levels, this is not something we typically do in the emergency department, but it is a risk factor for ICU admission and more severe course. Oxygen saturations less than or equal to 91% on presentation to the ED, and longer asthma duration. All of these may indicate a patient at higher risk of requiring ICU admission. The severity assessment score, called the PRAM score for asthma, is one that looks at suprasternal retractions, also known as tracheal tugging, scalene muscle retractions or intercostal indrawing, air entry, wheezing, and oxygen saturation on room air to stratify a child as mild, moderate, or severe. So in terms of management of asthma exacerbations, we would use oxygen to keep oxygen saturations greater than or equal to 90%, although there's no strong evidence in support of a particular goal for oxygen saturation. We use beta-2 agonists, with salbutamol being the most commonly used agent at our center. MDIs, or metered dose inhalers, are preferred over nebulized medications in all but patients with impending respiratory failure, and this is because it's just as efficacious as nebulized medications, but it has fewer side effects such as tachycardia and hypokalemia, and also it's a great way to teach parents and patients how to use MDIs because that's what they're going to be discharged with to their own homes. Anticholinergics such as ipratropium bromide, the trade name in Canada being Atrovent, are add-on treatments with salbutamol. They've been shown to decrease the rate of admission when administered with salbutamol within the first hour of presentation to the ER. After that, there's really no effect on admission, so we only use it on initial presentation to the emergency department in a child with moderate to severe asthma. There is strong evidence for administration of steroids within the first hour of presentation to the emergency department in kids with asthma exacerbations and known asthma. It's been shown to decrease the length of stay in the ED and decrease the rate of hospital admission. In our emergency department, there are two types of oral steroids that we tend to use: dexamethasone at a dose of 0.3 milligrams per kilogram per dose given for 2 days, or prednisone at a dose of 1 milligram per kilogram per day, once daily, given for 5 days. Both of these are once daily medications. We tend to prefer dexamethasone because it's given in smaller volumes, it tastes better, and it's better tolerated. Children have been shown to vomit the dexamethasone less frequently than they do the prednisone. So whenever you have a treatment that you only have to give for 2 days versus 5 days and it's better tolerated, it's a win. So I tend to stick to dexamethasone. For IV formulations, we use methylprednisolone, and it's given in a dose of 1 to 2 milligrams per kilogram per dose. Magnesium sulfate is given in more moderate to severe asthma with poor or incomplete response to bronchodilators within the first hour or two. It's been shown to significantly increase pulmonary function in children and decrease the rate of admission, in particular to the intensive care unit. So these are usually children who are just not doing well with our typical treatments. The mechanism of action of magnesium sulfate is not very well understood, but it works. IV salbutamol infusion is an option in much more severe cases where you've got impending respiratory failure. You need to monitor these patients. You need cardiorespiratory monitoring for these patients because there is an increased risk of cardiac arrhythmias, tachycardia, and hypokalemia with IV salbutamol. IV aminophylline is listed as a potential treatment, but just really not given in the emergency department, or at least not in our emergency department. And then as a very last resort, intubation and ventilation for impending respiratory failure, where the patient's just really not responding to all of our usual treatments. There have been shown to be significant adverse effects associated with intubation of patients with asthma exacerbation, and it's been associated with increased risk of death, as well as increased risk of complications such as pneumothoraces, cardiovascular collapse, impaired venous return. So it's something that we really try to avoid. The Ontario Lung Association's Pediatric Asthma Care Pathway is a great resource that helps guide management of children with asthma exacerbations in the ER. It uses the PRAM scoring system to stratify patients as having mild, moderate, or severe asthma exacerbations, where mild is a PRAM of 0 to 3, moderate is 4 to 7, and severe is 8 to 12. And then management is guided by that. In mild asthma exacerbations, you just give Ventolin and you reassess. In moderate, you give oral corticosteroids as quickly as possible, ideally within that first 60 minutes of presentation to ED, and then you give salbutamol and you reassess. In severe asthma exacerbations, you give back-to-backs, so salbutamol, ipratropium bromide, 3 times back-to-back, which means right after one another. And you also give systemic corticosteroids, however the patient will tolerate them. So if they'll take them orally, you do that. If they can't, then you give IV. And then you consider other treatments in severe asthma exacerbations and impending respiratory failure, such as the mag sulfate and the IV Ventolin that we talked about. What are the criteria for discharge from the ED? I tell parents that I need to see that your child can go at least 2 to 4 hours without requiring Ventolin, that their oxygen saturations remain above 90% on room air even while sleeping, because they do tend to desat more while asleep, that they have improved air entry and improved work of breathing compared to when we first saw them, and that the caregiver is reliable, so would be able to bring them back if their condition changes. So back to our case, this 12-year-old girl. If we take a look, she does have the suprasternal retractions or tracheal tugging, so that gives her a score of 2 on PRAM. She does have the scalene muscle retractions or intercostal indrawing, again another 2. We're seeing that she has decreased air entry throughout, so another score of 2 on air entry. Wheezing, it's hard to know from the case, but let's say it's expiratory only, so that'll give us a score of 1. And her oxygen saturation is definitely less than 92% because she's got an O2 sat of 89% on room air. So that gives her a PRAM score, a total PRAM score of 9, which would put her in the severe asthma exacerbation category. So we're going to manage her accordingly. And so we go back to our pediatric asthma care pathway from the Ontario Lung Association. With a severe asthma exacerbation, we're giving steroids immediately, however she'll tolerate them, whether orally or IV. And we're going to give salbutamol and ipratropium bromide back to back. So salbutamol, ipratropium bromide, and then salbutamol, ipratropium bromide, and then again salbutamol, ipratropium bromide. And then we reassess. We see how she's doing, and we base our next step based on her level of improvement with our treatment. So let's take a look at a couple of questions, some of which we've already answered about our case. How would you classify the severity of Aya's asthma exacerbation? So as we said, her PRAM score adds up to 9. So that would put her in the severe asthma exacerbation category. How would you manage Aya? And again, we talked about given her PRAM score, she's severe, and so we would manage her accordingly based on the Ontario Lung Association guidelines. That brings us to the end of this presentation. There are other presentations that you can take a look at. Hopefully you'll have benefited a little bit from this and from the rest of our presentations. Best of luck to you guys, and hope to see you in the ED. Take care.